All right. Good morning, everyone. Good morning, good morning, good morning. My name is Nia Bibb, and I am the Community Relations Specialist for Archwell Health Birmingham. And I am so excited and thrilled that you all have decided to join us today at our inaugural Men's Health Symposium and Health Fair. Clap it up. So thank you to all of you that have decided to join us today. I'm sure more people will come as the day goes on. But we're going to go ahead and get started because I am the person that believes in respecting people's time, and it is 10:09. So with that, I'm actually going to have Pastor Sellers, this, who is the pastor of this church and also one of the sponsors of this great event. He is also the State House representative for District 57. And so I'm going to have you open up, if you don't mind, with a word of prayer and whatever you want to say.
Good morning. Let us pray. God, we thank you now for this day and this time of sharing. Thank you for every single person that is here to share in this particular setting. Bless our efforts. Only in Jesus' name.
Thank you so much, Dr. Sellers. Dr. Sellers. And now we're actually going to have medical director Dr. Carter come up and open up if you do, and go ahead and introduce our first speaker.
Thank you. Good morning, everyone. Good morning, everyone. And good morning, everyone. All right. Uh, Happy to be here with you to Pastor Sellers. Uh, um, and all the other pastors. That's okay. Yeah, all the other pastors, church officers, everybody here. Thank you for having us here. Well, health. As you have said, I'm in the Institute for Birmingham. I'm for Archwell Health. And this is something that we are passionate about. In every community that we have centers in, our goal is to and to pour into the community because we believe that our mission is to make not just our members healthier, but our community. So thank everyone for coming up here. Thank in advance my physician colleagues for coming out to share some very, very hopeful and important information with you. So, without further ado, I want to introduce our first speaker. And so, here's the deal: I don't need notes for any of these speakers because um, not only are we colleagues, but they are my friends, and in many cases, also my doctor too. So, I know them well. But first, we're going to have a nugget on men's mental health. And so, June is also Men's Mental Health Month. And it is important that I think we start out talking about that. Because when we talk about men's health, we talk about blood pressure, prostate cancer, and all other things. We don't talk about men's mental health. And that is just very important, especially as we get older. We deal with challenges, opportunities in the area too. So our first physician speaker is Dr. Brandy Rudolph. She is a triple board certified psychiatrist. She is busy, about busy as I am, and practices and work all over the state. But she will come and speak to us mental health. And she has her wonderful husband with her, bless his heart, he's no make it, but that's all right. Fred Bowen, who is a newly elected judge, probate judge. It's probate, it's not probate. Circuit. No, excuse me. Dr. Randy B. Hello. I give it
course, men are targeted audience, but there's something for everyone who is here. So if you are a man, great. But if you are a woman, that's great too. If you have children, you will find something for them as well. As he said, I'm boarded in pediatrics, adult psychiatry, and child and adolescent psychiatry. So whatever it is, whoever you are, I can at least manage you until I get you to the right colleagues to help you from there. So actually, my husband is with me, and I was asking him about, well, I've got to go and talk to these men. What do men want to hear about when it comes to mental health? And his answer was probably what most men are feel. He said, if it comes to the things that they're interested in with their physical health, then so that is very much what a lot of people do think, but certainly not a good way to maintain your health. So our mental health is our health. Our mental health is our wealth. If you don't believe it, get mentally ill, you can't go to work. Get mentally ill, you are losing friendships. Get mentally ill, you're wondering where are you? Because something is not right. And because people cannot see it, we have an invisible illness oftentimes. That means that they wonder, well, is she crazy? Well, I want you to know right now that you're not. You just have a mental health condition. And I'm here to tell you what some of those are. And we're going to talk about it in church. Because, yes, you can have a psychiatrist and a therapist too. Everybody believes in the world. You can have all of them. You know, Jesus will. I know that. So for each of these, it's going to be quick. You want to stop and think about something else. I don't know that we have a question how you want to do it. But I'm going to go over criteria, how it presents, what is the code, what the Bible says about it since you're in church. Give you a quote and give you a concept, something that you can all make on your own and go get through. So the criteria for depression, that's what we're going to talk about first. Sadness, irritability, inability to sleep or sleeping too much, inability to eat or eating too much, um, concentration that's poor, feeling hopeless, and having thoughts of death. Well, thoughts of death can present in two different ways. One is, I just wish I would die. You can even take it to a prayer. Lord, please. Suicidal thoughts are very different. I'm going to make myself die. One of those is an emergency, the other is not. He can present with a lot of irritability, snappy. People are like, what's not with you? What's wrong with you? Or apathy. I always tell people, if you don't say a couple times to go shopping, and I say, I don't want to go more than once, check on me because I'm not okay. Because that's what I like to do. So your friends should know you well enough to be able to say, a couple of times I asked you to go over to that was supposed to be gone Friday night, and you didn't go. Does everything okay? And we all do this typically on a regular basis. How else do you present drinking, smoking? I'm not talking nicotine, which is also bad. Oh, waking between 2 and 4 in the morning. There is nothing to make you wake up at 2 or 4 in the morning like a good piece of depression or anxiety. All right? Where'd you go? Or call your favorite Bible verse. Talk to people around you. Check in on folks. And when I say check in on folks, I'm not talking about, girl, how you doing? Girl, I'm fine. I want to talk to you later. No. If you know she doesn't sound right, or he doesn't sound right, ask your own questions. Ask your own questions. We're all so busy. We don't not even pick up on how people really sound. Why? Because we're texting. But every once in a while, they're wild. Sin and in. All of these things are our world. What does the Bible say about it? Everything being beautiful at night, but joy cometh in the morning. And that's Psalm 75. So that's where our hope is coming from. When we believe in God, we know that our hope is in Him. So if So you need to hear that. It's not depression. It's not anxiety. I mean, but anxiety is the most common illness of this country. We're all just about something. About 5 years ago, we were about, am I going to die? Am I going to live? Am I going to have a job? When am I going to open a church? Why didn't I go to church? Why didn't I on Facebook on the church? All of these things are all worked up. So what is anxiety? Listen, uncontrol, inability to control, nerves, heart rate, sweat. Need to pull over. Am I having a heart attack? Okay, how do you cope? Say, just in your mind, raise your hand and say yes to it. Right? So in your mind, that's a lot of people that feel too much. My cousin was like, I thought she had to people the question. And then for every but we can do it, right? We think but sometimes no is all. And you know what? It's but you know, trying to figure out how to do it. You don't have to go to no lie. You have to be a lie. I'm not myself to say I can't, but you can. But you have to be able to use it as somebody. You don't know this that you can tell you all that. Because I can forgive you when you think college for this part. Okay? But you can tell your boss, my child graduates one day. And I understand that everything says, yes, the child is going to have one graduate. And you're right. You say you were going to graduate. These are things that we just have to learn how to say. The past is be anxious for you. But everything by prayer and supplication, that's good. It's always that number one you need to do it. All of the sometimes, well, look, your request is out to God. That's all. Go to today. If all your heart full of that's all. You're walking around and it's not good or something. I pray to God, it's not ready yet. They have no heart of out there. Like, how do you run this? What? Don't worry about the problem. It looks like you realize. So what is it? So first of all, it's about but it's real. You don't believe it is real. In the future, I was reading also young people category so there are two things that people forget to organize or participate in the council space. They don't think people they need to say, all right? The high particular compulsive, these are people who are talkative, loud, flirty, interrupting, always on the go, busy bodies, can't stay seated, fidgeting. Now, how does it present in men? Forget the back bills. She gave it to you. Envelope is still in the lights. Right? But now, once typically, everybody once irritability, this can be huge. Most times, you're really not going to just hoping that otherwise, are your friends? Cutting people off of conversation because your thought comes up and literally when you come out or you will forget. And it's because those of us that don't have ADHD, somebody tell us to make a video about jealous and we just good up to do it. But if you have ADHD, you got to practice about what it is. So when they breathe, you get to breathe in preparation because now you know that was what you want. And so you get back to the you know that it's your own will. You got to remember the mind, but you're not doing what you're doing. So I know is that your wife is not doing it. I need to know you think that all of the things that I'm talking about, if you how do you do things the same way? Giving yourself time. Simplify things. People need to say no. I'm not going to do it. Just take a few minutes. The PhD is somebody telling you problem that you need to just want to stop. That's the time. You can feel again that you are stopping it. That's enough. You can all feel, but you can feel like negative. Where you were destined to be, nothing is supposed to be there. Okay, you ever felt that? There are other people. I know my friends. I'm tired of like more. Sometimes that's not because that's not how. Sometimes it's because I want you to direction of a thing. I can adjust myself to always reach my destination. The last week, stuff I just see on the drop out of 100%. Drop out of, I'm sorry, only 5 to 10% of people that get you will finish college. I got a picture right now. That goes to 2 years. Right? Unless you work a little, drop out. You can work away. So you can do it. Whatever relates to the day, you can do it in the month. Always look at always any of the people actually what could the last one is almost everything. I want to talk about why this is good. They can follow up, but it needs to be spoken about. Somebody's not going to let that go. A lot of people out there. So this is something that is important. So I just want to be deeply picture of that. There's an impetus which what it takes to engage with something. Things are that's the impetus. If you're depressed, you want to be interested. If you're anxious, when I perform, would you like it? If you feel unappreciated, you know, you're stressed, and you feel, but I make 10 hours to 27 hours. I need help, but somebody told me that you do this. And I do it. That's what it is. Increasing age. Hypertension. So there's a whole lot of reasons to watch your sugar. You got to look at sugar. You got to learn. Take your medicine. And do it out before and all this how you add it before you're in after. It's good. Relationships for communication. Just so you in the morning when you wake up, the phone call. All right. Lack of awareness of conflict. Of course, lifestyle. Lack of exercise. Lack of sleep. And I already told you that if you sleep with your friends, you're going to wake up early in the morning. And if you wake up early in the morning, you're going to be too tired at night. You got and then not doing it. And denial is more denying things that not feel take care of the physical, emotional, any other conditions. Parking said that their first handicap, 3 spaces over. I apologize that I do think we are going to February meeting this closely. So I'm always happy to answer questions. This is my passion, and I know that the way that I look on I will come through it. The part of what makes me things I try to be able to take care of my life. So and we have a great
Okay. Y'all, if and if thank you, y'all. Safe travel. Right. But listen, before I bring up the kids, I just want to say, um, I think it's important to say this. Kim and affairs. You know, you know, you're president, you're anxious, whatever. and therapy, because it's therapy, it makes you feel just verbalize reduces your stress, mood, all of it. So I am an advocate every person, not just men, this is men's health. Every person having a therapist. At one point in time, I asked for I had two therapists. I got one locally, and he was so popular and so busy, I can only get him once a month. I said, I got to talk to somebody else for a little while. So I got people on one. So I have one I talk to weekly and one I talk to monthly. And when I said, okay, I feel better. So I just wanted to piggyback on that. I'm going to bring me up on social media.
So first, don't forget to go to first. Yes, then we had to run. And I know I'm talking about head but since I saw her when she was like 2 days. Just keep in mind that there are different. Come on up here, Davis. This is very
Good morning. Good morning. I am sitting here glad to see people we have here to my profession. See a lot of situations like, hey, look, we need somebody to talk to. Also, the officers, all the debates. But so that we can be the best. Give a shout out to our black nurses as well. Um,
Good morning. How are you? Yeah, thank you for
You put on a lot of when you said but help is important. Head. For sure. I'm very much and, my wife don't have to make me go. I got special doctors as well. Even though I'm standing here today, I'm very active. But we have good and no signs of which is fair and proper. Like, and what you ask the question, it is incredible. But you can't walk through it. What young lady came back there, she said, you know when to change your oil, or know when to PSA, when your oil percentage is your low hour back. Two of the other possible need to do a better job.
So as a raffle ticket is inside of your main card. The last three digits. First number 020. 020. Right, Miss Hubbard. Okay, Miss Hubbard. You can come on up and pick a prize off the table. The person's going to take over for you.
Ladies, we got the raffle this evening. I got the next zero twice. Zero, 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 two. That's what I said. Right. Next one. 070. Zero, seven, zero, eight, zero. Anybody out there got a 080? Next week, I'll take it. The three digits are 043. 043. Not bad. Yes, sir. Appreciate it, sir. All right. Zero, minus, zero, minus, ladies and gentlemen, I went outside this morning before and I hiked this morning. Wanted to make sure I pressed my luck. 021 is the next bracket. Zero, 0, 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0. 0, 9, 0
17. All right, my man. So I'm gonna stay on the daddy jokes for Father's Day. How about that? We're gonna stay on the daddy jokes. Oh my man, just go over to the table and just grab whatever you like there. Mm-hmm. Oh, that's a barbecue. Open it up. Yeah. So next, when they throw you on the grill, want to give you a real nice set to work with. Make the food taste better. 086. 086. So, Father's Day. Father and his son. Father wanted to take his son go fishing. They went down out to the Gulf, down in South Alabama. Went out on the Gulf, and you know what? The boat caught a leak while the dad and the son they out trying to spend some time. And the son said, "Dad, I'm finna hop off. I'm gonna swim to the shore, go get some help." And the dad said, "Son, don't worry about it. God got me." That's what he told him. Then a tugboat came on by. And he said, "Man, I can hook you up and I can pull you on down to the bank so we can get you taken care of." He said, "Don't worry about it. God got it." Then somebody came by with a speedboat. And the man told him the same thing. "Don't worry about it. God got it." And you know what happened? The man drowned. The man drowned. And he gets to heaven and he said, "God, I thought you said you got me." He said, "Who you think sent the tugboat and the speedboat?" Yeah. I liken doctors to God sending help. Sometimes, the doctors have been blessed and have studied to show themselves to be approved, and they're coming to give you some help. God sent that person by you. 033. 033 is the next ticket. Wait a minute. Did I already call 003? I saw this one on the floor. Did I call off this one? All right. Oh, that's you? Okay, I got you. My man. All right, that's my brother Carter. Let's do it. All right. Next ticket up is 075. 075. I'm alive. 013. What you got? What you got, Miss Carter? Gracias, senor. 014. 014. 089. You know what you call a cow with no legs? Ground beef. I'm telling you, I got all the daddy jokes Father's Day. I got them. I got them. You like that one? All right. 025. 025 is the next one. Oh, 25, I'm alive. Knock yourself out. See what we got over here. Next ticket number 063. 063. Oh, all right, all right. Oh, no, yeah. Appreciate you. You got to open it up, man. There's a box. 079. 079, I'm feeling fine. This that bingo. This that bingo number. 066. 066. 091. 091. 012. Somebody asked me earlier today, why are there so many churches named First? Why don't we ever see a second or third? And I tried my best to explain the culture to them. I really did. But you know what? I thought about it. We do got a lot of first. And we got a lot of new. We'll never see like old Baptist church. We'll never see that. 087. 087. 1987. That was a good year. 031 is the next ticket. 031. 050. Next ticket is 064. 064 gonna knock kick in the door. I told you 064. I knew it. I felt the energy on that one. AARP is the place to be. 099. 099. Well, ladies and gentlemen, I think it's been my time. I hope y'all have enjoyed the. Yeah, we just.
Okay, thank you. Thank you for your patience, everyone. Dr. Carter is now going to introduce the next speaker.
All right, I'm back, y'all. Ooh. Y'all doing all right? All right, good, good. We have a little adjustment in our schedule for our next speaker. We're going to bring up Dr. Stone because he has a pressing meeting to get to. You okay with that, Dr. Lee? Thank you. All right, so Dr. Brian Stone is a urologist. He owns his own practice, runs his own practice in the Jasper area. But Dr. Stone is not just a urologist, but he is a philanthropist in this community. He is very engaged in health and health policy, has advocated on a national level, has gone up to Capitol Hill in DC and advocated and testified on behalf of our health here in Alabama, men's health around the country, particularly Black male health. So I am very, very honored to be able to present to you Dr. Brian Stone.
Thank you, my brother. Thank you. Well, good morning, everybody. If you don't know what a urologist is, I'm a surgeon of the urinary tract, so I deal with kidneys, bladder, prostate. I deal with cancers of the kidney, the prostate, the bladder, testicles. I deal with pelvic floor problems in women where after a hysterectomy or too many babies, things start falling out. I fix that. I'm currently president of Jasper Urology Associates, which is in Jasper. I have an office in Gardendale once a month. Walker Baptist Medical Center is part of now the Orlando Health Baptist Health Network. We're very happy to have them over Tenet. Tenet was like locusts. All they cared about was shareholders and not the patients or the community. I've been spending a little time reading the Hebrew Bible because I wanted to look at source materials. And one of the things I noticed in early times, we lived a lot longer. You know, people there to be 175 years old, 140 years old. And so I started wondering, like, why, what's so different now between those times and now? I think the environment has changed. The food we eat has changed. We've introduced a lot of synthetic materials into the environment without, you know, we're just creating things without considering the unintended consequences. I don't know if you guys have heard about microplastics. Well, all the garbage that we've generated is in the oceans, and the fish are eating the plastics, and we have plastics in our bodies. So a lot of these chemicals and things are leading to a lot of the cancers that we see. They didn't have as many cancers several hundred years ago. It was kind of a different world. So it's very important for us to think about men's health is bigger than just the prostate. It has a lot to do with the mentality of how men approach health. A man is not like a woman. You know, women take care of things. They get a problem, the majority of women will go and address it. A man does not address anything. You know, we're trying to put on a persona of being tough. We are afraid, you know, internally, you know, we fear diagnosis and getting things done. But if you want to live and have a healthy life and be able to function the way you are now when you turn 90, you need to start making investments now. And part of these investments include your diet, um, going to see a physician, getting checked on a regular basis. I was very impressed with the gentleman earlier who talked about knowing your PSA number. Um, it's bigger than just prostate. So I get men coming to me now. We're seeing low testosterone. I'm seeing it at much younger ages. Like 20 years ago, most of the low T was guys over 50 and 60. Now we're seeing 20-year-olds and 30-year-olds with low testosterone. It has a lot to do with obesity, body fat. In the man, the gut fat makes a chemical called aromatase. It converts your testosterone to estrogen. You may look at yourself in the mirror and wonder why you got breasts. Well, that's why you got breasts. So focusing on getting rid of your gut fat helps with testosterone. It reduces your cardiovascular risk. When you get a big gut, your risk of heart attack and stroke as a man is significantly higher. Your risk of diabetes is higher. So looking at your global health is very important, which means you need a primary care physician, you need a therapist, you need a pastor, you need a urologist, okay, especially after the age of 40. Your prostate is a small gland that's between your bladder and your urethra, which is the tube you pee through. Women don't have one. This is just something that a man has. It's small until you turn 30, and at the age of 30, it starts to grow, and it grows every year until you die. The relationship would be like if you cut a hole in an apple and put a straw through it. As it grows, it starts to squeeze this pipe, and that's what causes you to have to get up at night to pee, or when you get the urge to urinate, you can't hold it. You're in a rush. You might have burning when you pee. You may be dripping. You know, you pee, you shake, you shake, you shake. You walk away, you still stain your pants. That's your prostate. The reason the rectal exam is important is because most of the tumors that occur in the prostate are on the back. So we're checking you for bumps. It's not 100% necessary, but there are cancers that won't elevate your PSA that will present as a nodule. So the doctor's not trying to violate you. He's just trying to make sure you don't have something that you don't know you have. The PSA should be checked. There's a lot of controversy about when to check PSA. We spent the 90s up into the early 2000s trying to get men, especially black men, to start getting checked. And we made significant strides until the United States Preventative Task Force Service gave the PSA a D grade about 7 years ago. Then a lot of PCPs, out of the confusion, stopped checking PSAs. That was a death sentence for a lot of black men. Black men have the highest death rate and incidence from prostate cancer in the world. It's like the biggest cancer disparity in the world. We don't know exactly why. We know it's genetic. We've identified a gene that left with the slaves and migrated with us here that has something to do with it, but it's something about being in the United States that makes prostate cancer worse in black men. It's probably diet, it's probably environment, but we don't know. So until we know, you need to start getting yourself checked when you turn 40. If you have prostate cancer in your family, I've had 5 people in my family. I started getting checked when I was 38. You need a baseline PSA. It's not so much the absolute number as it is how fast it's going up. If your PSA is increasing greater than 0.75 over a 12-month period, that's abnormal. So if I saw you last year, you had a zero point 0.8, you come to see me and it's 2, I'm doing an MRI of your prostate. I find a lot of prostate cancers, and the goal is to get the cancer early so you got all your options on the table. Some of the options may include not doing anything and just observing you to see if it's going to grow, but you need to know if you have it, so you have your options. Because when prostate breaks out and it gets in your bones and your lymph nodes, the burden of having to take care of you when you're disabled is going to be on your family. So ignoring things is being selfish because your family is going to take care of you. Prostate cancer does not kill you like a heart attack. It is a very slow and painful way to die. And it's not something you want to go through. And you don't have to, because right now we have so much good technology. I'm working on bringing a treatment. We'd be the only one in Alabama to have it. It's called focal therapy. The new focus is to try and treat the tumor so you don't have to remove the prostate or give big doses of radiation. So the risk of erection problems and leakage of urine is low. It's called HIFU. It's high intensity focused ultrasound, and it's going to be coming soon. And I like it because we now have something called PSMA PET scan, which can identify prostate cancer cells anywhere. So with the focal therapy, you'll be able to tell if it works because you can do a PET scan, and should it be one of those cancers that's aggressive, you can still have surgery, you can still have radiation. So this will be something coming. So men, I say don't be afraid. I think you should be afraid of the unknown. You need to know. You need to know what your blood pressure is. If you don't take care of your blood pressure, you don't have issues. Erection problems are one of the early signs of heart disease. There's been several studies. When I get a young guy in his 40s that's having bad ED, I'm thinking he probably has coronary artery disease, and I might refer him to a cardiologist. Um, One of the biggest scourges we have is cigarettes. Nicotine it causes kidney cancer, bladder cancer. It causes hardening of the arteries, so your erections go away. You have got to get rid of the nicotine. It's probably one of the leading causes of stroke, heart attack, and I'm sure Dr. Lee, the cardiologist, is going to talk about it. There are ways to wean yourself off of nicotine. I would say do it at all costs. I get my patients on, they make a green tea tobacco that comes in pouches. It has a high caffeine content, so it feels like nicotine, but it's safe. It's a way to transition away from that old habit. Um, Exercise, very critical, and it even may reduce your risk of certain cancers. It'll reduce your risk of diabetes, heart disease. You need to exercise. It doesn't have to be lifting weights. It means tracking your steps. I have a lot of patients that say, well, doc, I walk a lot at work. Work is work. Exercise is when you set aside 45 minutes and decide, I'm going to walk and I'm going to do 3 miles. And doing this 3 times a week would change your life. Um, so my recommendation is when you hit 40, every man should have a urologist. We know everything about men's health. We know how to safely perform hormone replacement therapy. A lot of places just give testosterone shots. Well, synthetic testosterone is a high risk drug. It can stimulate your bone marrow to make too many red blood cells, causing something called polycythemia, putting you at a risk of stroke or heart attack. So it's nothing wrong with being on testosterone, but you need somebody who knows how to treat you properly so you do it in a safe way. A lot of people don't know testosterone makes you infertile. So as a young man with low T, you don't want to be on testosterone. You want to be on something called HCG that will stimulate your body to make more testosterone in a safe way. So it's important to have a expert that knows how to do these things properly to keep you safe. I promote having erections. Everybody should feel good. You need your testosterone for energy. For women, I do the same. Women go through the same changes. So I get men where I fix their erection. Now the woman is like, look, this guy, you made him 20 years old, but I'm not 20 years old. So you get on your estrogen replacement therapy, you get on a testosterone cream, it'll change your life. You need testosterone for your arousal and your desire. The estrogen will fix the area so things are more like they were when you were younger. So don't be afraid to be on hormone therapy. Even if you're concerned about your breast, as long as you're doing your mammograms, you can do the replacement therapy easily. As far as urinary incontinence, I don't think anybody should be wearing diapers. We have a lot of options for overactive bladder syndrome. There's a stimulator that I implant in the lower spine where the nerves are. Something happens in women when they get past menopause and the estrogen levels fall, the bladder gets overactive. And this is when you get an urge and you just can't stop it. I don't care how much you pinch up, you're just gonna pee on yourself. Uh, Leaking when you cough or sneeze, that comes from stretch sphincter muscles from having too many babies, or maybe you've had a hysterectomy. We can fix that. But I think everybody can be dry. Don't be afraid to seek help. Diapers cost a lot of money. The pads cost a lot of money. And you can use that money for something else. So my recommendation, don't be afraid, don't be embarrassed. This is something we deal with on a regular basis and it can be fixed. So I'm Dr. Stone. My practice is in Jasper. Dr. Carter knows how to reach me if you need me. And take care of yourself, man. Take care of your life. Yes, sir. Okay. Okay. So the PSMA PET scan is something that's done once you've been diagnosed with prostate cancer. We have certain guidelines for when the PSA goes to a certain level, when to perform it. But it's an excellent test now that lets us really see prostate cancer cells. CT scan won't do it. Bone scan will probably miss most. The regular PET scan won't pick it up at all. But this PSMA scan, it's a very new and amazing thing. Very useful. Focal therapy. It testosterone. It's HCG. So your pituitary and hypothalamus regulate the ovaries and testicles as far as producing estrogen and testosterone. So HCG will stimulate your pituitary to tell your testicles to make more testosterone. So it's basically your testosterone versus the synthetic. The synthetic is linked to things, so it can have side effects. Hmm. 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 Yeah. Mhm. No, that's not it. So the estrogen level is rising because of your gut fat. The gut fat is making a lot of aromatase. So that's treated with an aromatase inhibitor that we give you to help you balance. But this is what makes the aromatase that drives up these estrogen levels. And I see a lot of it, and a lot of the docs don't check it, because you got to know that, because you can be given testosterone, but the peripheral conversion, you're just feeding that process, generating more estrogen. So you have to be on an aromatase inhibitor so your testosterone goes up like it ought to. Yeah, a Remedex. Yeah. hmm I don't know the pituitary issue you have because that's where it works. Yeah, it may not work, but it's possible. I'll give you my info. It, yeah, you need a good communicator when you get a physician. That's the key. I just fired my PCP because he just didn't talk. I made him nervous. I have to tell him to check my prostate, and you need a good doctor that'll talk to you. Don't want to be your own doctor any more than you want to be your own lawyer. Okay. Hey, well, thank you, everybody.
Thank you, Dr. Stone. I appreciate it. That was good, wasn't it? I ain't gonna say he made me want to go get my prostate checked, but it's about time. Next month, I gotta go next month. Y'all pray for me. It's not that bad. You know what else is not that bad? Colonoscopy. I had my first colonoscopy a few years ago, and you know, now the day before, the prep, you know, but even that wasn't so bad, you know. Get you some Crystal Light, a big bag of ice, and just keep it cold. Stay by the bathroom. It's easier now because you got Netflix. So you just turn Netflix on and just watch it all night because you ain't gonna sleep. And get you some baby wipes. But then when you go for the actual, you know, colonoscopy, easiest but best sleep you ever had. I was talking to the doctor. Next thing I know, I was in the car, right? I looked up, I said, who dressed me? My wife said, you dressed yourself. I said, if you say so, can we go to Milo's? Because I was hungry. Yes, Lord. But yeah, and I said all that to say a prostate exam ain't nearly as bad as a colonoscopy, and a colonoscopy ain't bad. So, but I appreciate Dr. Stone for that. Listen, we're in for a treat now because this doctor coming up next he's a colleague and a friend, but he's also one of my doctors, you know, and you know, I trust him because he's played around in my heart before. He's played around in my heart before, and I'm still here. I turned around all right, didn't I? But we have Dr. Timothy Lee. He's an interventional cardiologist, and he and his wife have their own cardiology practice here in Birmingham over at Brookwood Hospital. Her name is Dr. Annabella Simon Lee, and we got Dr. So power couple, and he's got daughters, twin daughters, so it's gonna take two cardiologists to get through college, and them two weddings he gonna have to pay for. But Dr. Timothy Lee is a wonderful cardiologist, heart specialist, but he's just a wonderful human being, Christian, very involved in the community, always giving back. And when I called him and asked him if he would mind coming and sharing with you I think he said yes before he even knew the date. Then he, wait a minute, what was the date again? And I was like, Lord, when I give him this date, I hope his answer don't change. But it did not. So Dr. Timothy Lee is going to come up and talk to you about the matters of the heart. Thank you, Doctor.
I'm gonna put you to work. All that. Yeah, give out some of these handouts for me.
yes.
Because I forget. Give me one of them because I gotta. Good morning. Is it still morning? My watch broke on my way in here. Good morning, everybody. My name is Tim Lee. I'm not going to be very long up here. I think most of us here, I didn't know what crowd to expect. I didn't know if this was like a layperson's crowd, but all y'all seem like y'all are medical people. So I don't want to talk down. I just want to kind of maybe remind you of some things that we need to be concerned about and with our hearts. So much of my training was actually in the military. I spent 14 years in the Army. My wife is in the Navy. We had the pleasure of training with some great people in the military, who and spent a few years in Boston in the Harvard Medical School system, did some research. And then we got pregnant with our twins and decided we were going to come back home to Alabama where my mom and my father could help us raise our girls. And so thank God we could get free childcare is what brought us back home. So we've been here for roughly 15 years. And we have our own practice. So thank God for that. So heart disease, I think we all know it's a big deal. It's the number one killer of people in this country. Um, Number one meaning it's above cancer, above prostate cancer, above all else. And then if you look at specifically at black men, it's the number one killer of us, particularly above the age 40. If you look less than age 40, what's the number one killer? Guns. Guns. Homicide is the number one killer. And that's unfortunate, but that's a different topic. So if you make it past the age 40, you're probably gonna die from heart disease. One of the gentlemen who spoke earlier, I forgot his name. He mentioned that he had a widowmaker blockage, and he was walking 4 or 5 miles a day. That's important. And I just want to kind of mention that as an add-on. Half the people who present with sudden cardiac death have had no warning. They are walking around, very much sitting around listening to lectures like we're doing right now. No problems. So that's what we're trying to catch. We don't want you to have that sudden cardiac death. I mean, you're really cardiac arrest. So I'm happy he mentioned that but what do we do to prevent that? And that's kind of what we want to focus on today. How do we prevent that kind of episode? So there's a key piece, a good rule of thumb is to know your numbers. And one of the nurses here, Birmingham Nursing Association people mentioned that earlier. So what numbers do we need to know? We need to know our blood pressure, our A1C, diabetes control. You want to know our cholesterol levels. You also want to know, and you probably won't know your family history. Some of us know if you had a first degree relative with heart disease, but you can't change that. We also don't want to start smoking. If you haven't started smoking by now, you don't want to start smoking. African Americans for a while we liked our menthol cigarettes, and that was kind of what we do us in. But the cardiac risk factors as a whole are age. You have higher risk of heart disease as you get older. You can't change that. You can't change who your mom and daddy are. That's family history. But you can change your smoking habits. You can control your diabetes. You can control your cholesterol, and you can control your hypertension. So that little handout, my military mind tells me I'll talk too much and I'll start rambling. But this little handout has about 5 good pages in it. And the first thing you'll see, I kind of made it more focused on black men. One of my colleagues, I was in the cath lab yesterday doing an angioplasty, and somebody said, asked the techs, if y'all were giving a lecture to a group of black men, what would y'all want me to tell these black men about heart disease? Well, they said, tell them about blood pressure. So I'm going to tell y'all about blood pressure. That's the most important thing, hypertension right now. So, well, we already kind of talked about the first part. Um, Again, black men as a whole, we're 70% higher risk of developing heart failure than white men. And all that is not, and some of these outcomes we'll see, and there's been a lot of research with this. Some of our poor outcomes is not all just about race. There's other things, social economic determinants, and other things that we have to factor. Hypertension is high blood pressure is one of those things that I have had a big interest for a while. There's a big book that we have in cardiology by a famous author called Eugene Brunwald. And specifically, when I was first becoming a cardiologist back in 2000, I was trying to figure out why do black people have more hypertension or more resistant hypertension than other races. And it has one little paragraph in there. And trying to explain that in one paragraph, is it genetic, what have you? The way it was explained in this one paragraph is that black people, as we come in from Africa, before we came over here in those luxury liners we came over here on, we were over in Africa, but the majority of us were there, and we had more drier conditions where we had to go without fresh water. And in doing so, we had a genetic potential to hold on to sodium, which also helps us hold on to water. So you have a gene that's pre-programming you to hold on to sodium, which is a good thing in those conditions. But when you come over to this country, that's not such a good thing when you're eating high sodium foods. So now you've got a situation where you're raising your blood pressure higher because some of it's diet, but some of it is genetically where your body is holding on to sodium. That's the reason why medicines like diuretics may work better in black people because it helps us get rid of sodium, and calcium channel blockers also works better in us, so it's been said. But I'm just going to go page by page because I'll talk too much. This next page, I'm messing up the lotto numbers. I'm sorry about that. This next page is what I really want y'all to understand. I used to ask, what is normal blood pressure? And normal blood pressure is 120 over 80. And as my wife would say, there's no such thing as a little bit of blood pressure. It's called a silent killer for a reason. Silent. Because you can have a blood pressure of 200 and something and feel good. And that's problematic because the higher the pressure, the higher your risk for strokes and heart attacks and kidney disease and needing dialysis. So 120 over 80, I put that in there just as a reminder of what the normal blood pressure would be. One thing I want to mention in this talk is I want to make sure we're empowering you. You have to take care of yourself. One of the other speakers mentioned it before. You have to take care of yourself, knowing your medical problems, because you may have the best doctor in the world. You may have a great doctors, but if you're not proactively fighting for yourself, you're not going to get what you need. And part of this is just educating you to know what questions to ask. So when you see your doctor, you'll know, I heard somewhere 120 over 80 was a normal blood pressure. My pressure is not 120 over 80. Should I be doing something different? Should I have my medications changed? Again, you have knowledge, a nugget that you can take and share with someone else and say, look, I got to get this pressure down. 120 over 80 is where I need to be to decrease my risk for having all these problems with kidney disease and dialysis and strokes and heart attacks. So, if nothing else, I want to leave you with that concept of knowing your own health, your own numbers. The next page, I know most of us know this, is how do you take your blood pressure at home? All of my patients who I see, I instruct them to buy a blood pressure diary. If you have hypertension, a blood pressure cuff. Someone got the lotto ticket and got one. That's invaluable to any patient. I believe anybody over age 40 needs to have their own cuff, whether you have hypertension or not. You can check your pressure at home, and there's a way to do that. And this just kind of outlines the things to do. It tells you don't smoke, and it gives you 30 minutes after you eat and these things. But invariably, the one thing I see people that they don't do, they don't wait 5 minutes, resting 5 minutes before they take a number. I call that they're taking it on the run. Your doctors ask you to give them a diary of your blood pressure and your heart rate, just writing it down and bringing it to the clinic. Some of y'all may have already plugged in with you when you're taking it and it's monitored by some nurse and it goes to the nurse. But for some of us who don't have that set up, taking it at home. Armron, I'm not endorsing it, but Armron makes a cuff that's already been certified. Walgreens has a wonderful, inexpensive cuff that I love to use, that one. And it goes across the arm. It has to be one on the arm, not the wrist. It has to be the arm cuff. So knowing how to check your blood pressure, I'm not going to repeat that, but that's part of taking care of yourself. I find that when I have patients that I see who come to me, they've taken their blood pressure and vital signs at home, they're not to be messed with. They're about their business. That tells the doctor two things. I know how to take my blood pressure at home, and I'm not here to play with you. I'm here. I've got my numbers right here. I'm depending on you in this alliance to help me navigate my health. But if you can't do it, show me somebody else who can. That's something that you don't have to be nasty with anybody, but you're showing the doctor that you are about your health and you mean business. So I'm coming in here right now letting that's your right to know your how to take care of yourself, right? So again, taking care of your own numbers is that should be the mantra here. Um, The last page here, the last few pages is just talking about salt intake and why do you need to limit your sodium. As I mentioned before, African Americans, sodium is a killer for us. And they give you there's really no set limit for sodium. They recommend that most people stay less than 2,500 milligrams. For my people who have end-stage kidney and my black people, I stay less than what, 1,500 milligrams or less, like a quarter of a teaspoon. That means you've got to really be aware of what you're eating and what you're ingesting into your body. There's labels on everything at the store. If you're buying pre-cooked food and processed food and these things, that sodium content, if you say I can only have 1,500 grams and the thing has 500 milligrams, 1,500 milligrams and it already has 500 milligrams on the label, you can't eat that. I don't eat anything with more than 20% sodium content. If it's less than 20%, I can't eat it. It will raise my blood pressure. So I'm a stickler for knowing, I know why to say 20%, probably should be 15%. But all of us kind of make these decisions. When you're eating at Papados and these places or out here, what's the one that's over there in Summit, when all the, when everybody eats that on Friday night? I don't know. I don't go there. It kills me. No, it's at the Summit. It's like, Cheesecake Factory. Oh my God. They cook that pasta in so much salt, and I taste, I can't eat it. The girl said, "That's me. You're trying to kill me. I mean, I'm not going to eat in a Cheesecake Factory with you. I can't even eat cheesecake. I'm lactose intolerant." So I'm thinking to myself, I'm not going there. I can't eat the food. So being aware of the sodium content. Now, every now and then, as a cardiologist, I will have a little cheat day once every 3 months. I get me some McDonald's French fries, but I'll say no salt. I say, give me my fries with no salt, and I can sneak it. As long as my wife can't see the evidence, I'm good. But I'm a black guy from Lower Alabama, and so all cameras are off. But we are human, but we all have to have that one little cheat day in there. I mean, I'm a plant-based eater. I eat mostly plant-based stuff. Anyway, I don't eat any steak and pork. I've given that up several years ago, but I'm more lean white meat, fish, and vegetables. So that's in the dietary. But sodium is the killer. You can read through that on your own. And the last thing I will leave you with, there's some dietary things in here, and then some. Not that I'm trying to do any gratuitous marketing for my practice, but this is just an idea how we have our patients make a diary for us. On the last page, you can scratch that little Alabama Heart and Vascular logo off, but you can take your vital signs the way the outline says do it, and just write down the date, the time, and before your medicines, take your vital signs, because in the morning time, if you notice, if you take your ratings at home, it's going to be higher in the morning. Why is that? Because hormonal changes. You've got diurnal rhythms, you've got aldosterone, cortisol, all these hormones are peaking in the morning. So most people come in, they wake up with their strokes. Like we have a thing in the hospital say, cold wake up stroke, where they woke up where the pressure was so high. I do want to step back, and one of the things I kind of heard from I think this gentleman right here, he mentioned him having migraine headaches. And one thing I said, have you been checked for sleep apnea? Sleep apnea is a big deal for black men. If you look at across all races, and one of the sources for this, they said that black men they're the only group that's substantially gone up in terms of sleep apnea mortality. So sleep apnea is something that is insidious. You know, people who have, if you have headaches, if you find yourself you wake up with headaches, you're fatigued. And again, I have sleep apnea. Full disclosure, I have a CPAP machine. For years, I thought I had migraines, and I was told in the military you have migraines and all this stuff. But I felt very tired through the day. I felt headaches, and my pressure was hard to control. And so that's something that's an easy thing to assess for is sleep apnea. So again, the take-home points are really just take charge of your own health care and find a good doctor that you can work with. I think the constant thing I've heard from all the speakers is find somebody that you feel comfortable with, that you can work through your medical, because it is a relationship. It's a contract. It's a bond. It's almost like just you got to have somebody who you really can talk to help you. You don't have to know everything, but have an idea what you what you need for your own health care, and be proactive when you can. Do I have time for questions? Any questions about anything I found that? Yes, ma'am. Mhm. So the question was, a person has hypertension, has high blood pressure, and how should you manage it? What do you need to do at home? So A good example is that little diary, that little sheet. Write the numbers down. Write those numbers down in the write the numbers down in the morning time, and then that's because you're documenting before medicines. Because most people take their medicines in the morning, right? So you write down that first reading. It's going to be high, and then I tell my patients to at least 6 hours later. Because when you want to give that medicine time to work, we do it at least twice a day. And I have some patients who will come in and they will have a whole 3 months worth of numbers. And they're about their business. And I can see exactly what happened every day. Well, I cheated that day, or I forgot, I had to rush out with this day, or my daughter came over and put the grandkids off that day, or what have you. So they've got all those little notes in the margins, so I know what happened. And it's good to know that because you can see where the outliers are, and you kind of do it. You can kind of do it. And for us, we have them circle before and they circle after. We always tell them don't take it any earlier than 6 hours before. You can take it 8, 12 hours after, but don't do it before because that medicine has to peak. You want to get a full effect of your pill of the medicine. So twice a day is what we say. And maybe your doctor may say, but that gives us a good idea what you're doing before your medicine, and we can see the response to the medicines. But the key is wait 5 minutes. I have people wait, and nobody's going to do that. I say wait that 5 minutes, put the cuff on, and have you're sitting at the kitchen table or the breakfast nook, feet flat on the floor, like the little diagram said, and you're letting that time for that pressure to settle. Listen to a gospel song, your favorite artist. Don't watch the TV, don't be yapping on the phone. Fighting with the kids, the grandkids, watching Fox News, whatever, and just kind of just letting your pressure settle down, and write that number down and give it to your doctor. That way they can shoot that they tweak something if they got it too high or they have it too low. One thing I tell my patients is, what is too low? What too low really is if you're taking your medicine and you're lightheaded and dizzy, it's like you're going to pass out. That's probably too low. Check your vital signs. And just sometimes people get a little dehydrated, and that's not really. It's just like But in the house, if you're following our patients in how, and we won't give you your pressure. We'll say it's repeated because 110 is sort of on the lower side of normal. And if you're older, say over the age 70 and 80, there's a phenomenon called orthostasis, where your pressure will actually drop lower when you stand up. So you have to be on the lookout for, you can be too low sometimes on those blood pressures. But talk to your doctor about that part of it. But we're shooting for 120 over 80. We're shooting for. All right. Any questions? Yes, sir. Mhm. I think that comes from well, what the American Heart Association would say on the table. If you look at the diagrams that you have from the American Heart Association, they have that arm resting on the table with the cuff. So in that illustration, that's what they want you to do. Now, can it be more accurate above or below? We always have it up. We have a machine. Our arm is at heart level. For whatever reason, that's kind of by convention how we've always done it. I will have to look that up and have to give you some other. I just know I don't know the answer exactly why we do it. It's just the way I've always been trained to do it. I don't know if you're having it down lower has it where it's more constricted or what have you. There shouldn't be much of a pressure difference with it being down. But it always has been that I've taken it where it's always been at the arm has been elevated at heart level. Interesting point. I do know that sometimes people can have subclavian stenosis where there's a stenosis in the artery. It may be less likely to have that effect in the artery that comes off of the aorta called the subclavian. It may be less likely to get that effect if it's raised as opposed to being lowered. I don't know. But it is, the American Heart would say, at heart level on the table, feet flat on the floor. That little diagram, how they have it listed there. So that's where it comes from. But mhm. Mhm. Gotcha. I see your point. I see your point. But are you sitting flat with your feet flat on the floor? Where is the cuff? Where is the machine? Okay. All right. Gotcha. Right. Right. I think just for just for being in line with what the guidelines say, they would want you to be not on the bed. They would want you to be at the table, and that's what because consistency and again that comes more from that guidelines. But I have not ever thought to question it. You know how you get indoctrinated into something that's been there and done that way for years. Laying in the recliner on the sofa, sitting, even though you're sitting up, it still would probably may give you a variance as opposed to being flat on the floor, straight back chair, arms at heart level, and consistently that way. That's the way the American Heart Association has recommended. And I've got to say that because the cameras are rolling. And, you got me. But yeah, I want to I want to look into that. But why do we do it that way? Thank you all for your time. And one more question. Yes, sir. Yes, ma'am. So I do know this because my sister is works at FAMU and she drinks coffee incessantly, but it will raise your blood pressure. How many points? I think it's like 7 to 8 points it can raise it, but depends on caffeine content and these things. I don't know, but caffeine is but it does tell you do not drink any caffeine within 30 minutes of taking your number because it will raise the number. It is a stimulant, and it can speed your heart rate up and it can raise your blood pressure. So you may be getting false elevations from drinking caffeine. They say no tobacco smoking, nicotine, stimulant. It can raise your blood pressure. And I think in that little hand that I gave you, it talks about not doing certain activities. Go empty your bladder before you do your blood pressure because that having to go pee and being in that tight raises your blood pressure. Those things. So that little handout may answer some more things that I'm skipping through right now. And they do have websites that you can go to within the handout to get more data about that too. Yes, ma'am. Hmm. You are saying exactly what all doctors' offices do. And we do it in our office. We run you through because we got to get you in that room because the doctor's go. My medical assistants know I'm going to be mad at them if they put you in that room. So what happens with that? That's why we have you do the home readings. The white coat syndrome is real. You come into the doctor's office, the doctor's running late, trying to get the copay out you. The parking lot's full, you can't find a parking spot, and then the doctor's still late. Your pressure high, and so we kind of use the home readings to kind of help us kind of really know who you are. You're at home, you're in your own environment, peace, quiet. Take it at home and bring those numbers to your doctor's office. That's what we do as well. We scan the copies in. So you hitting it, you got like, but invariably everybody does that. So I can't. That's just, yeah. So thank y'all for you. Mhm, mhm. I didn't know that. I didn't never have never heard that. Automated is the one, and some of those are have been certified to be. If you look at the certification on which book of have been certified, Omron number da 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 means it's accurate. And so I don't know that whole 20 points off thing. I've never heard that before. So that somebody's they messing up somebody somewhere doing that. Um, we're gonna be quiet on that. Thank y'all for your time, and thank y'all for listening.
All right. Thank you, Dr. Lee. And listen, he made some people came up and said, "Can I get extra copies to share?" Absolutely. We'll leave them here, and you know, y'all don't fight over them. Just take. But I will say this: several good points. The recommendation is blood. Your arm is resting at heart level. All right, want to be heart level. So, and yes, cuff going around your arm, not your wrist, not your forearm, none of that. Yeah, I see all kinds of stuff. Put it on your calf. Lord have mercy. No, don't. Just tell them don't take my blood pressure. Don't. There is a website. You can just Google Validate BP. Validate. You get your parking validated. ValidateBP.org. And they have done the research and kind of ranked. They've certified blood pressure cuffs, blood pressure monitors. So I share that site with my patients sometimes. Also, at Archwell, at Archwell, what we do is when you come in and that initial blood pressure is elevated, our nurses and medical assistants are trained to retake that blood pressure at least two more times. So we're going to repeat it at least three times because we do recognize that sometimes when you walk back from the front, came back, da, 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 hey girl, how you doing? And then you sit down, that first pressure is going to be up. So our medical assistants and nurses will take it an additional two times. What I do, if it's elevated, by the time I get in the room, it's still elevated. I'm going to recheck it myself, and I usually recheck a manual blood pressure. And um, from there, I always advise my patients to monitor their blood pressure at home if they take blood pressure medication. Also, we have wonderful ways now with technology that we can kind of help monitor you at home. It's called remote patient monitoring, where you can get a certified blood pressure cuff sent to you. You check your pressures, and then that information is sent somewhere where you get a report, and they can call you if it's too high, too low. If you have heart failure, there's remote patient monitoring for that. If you have uncontrolled diabetes and your blood sugar is too high, there's remote patient monitoring there. I see Dr. Pauline here, and she is with Med Plus Consulting Pharmacy, but they do more than just pharmacy. Let them say, hey, um, I I have referred several of my patients to her because her uh, practice offers remote patient monitoring. So there are, cardiologist offices are doing it now. Some primary care doctors' offices are doing it now. So there's all kinds of ways that we can help you monitor your pressure and stuff, at home. He brought up another excellent point about sleep apnea. Yeah. Sure. Yeah. Came back for us, y'all.
So
Now don't add this on to my bill.
no, I won't.
Okay.
But look, a lot of people, I see a lot of men they think they have low testosterone, and the testosterone is normal. They're still having extreme fatigue. They have a company now that can do a sleep apnea test at home. And what I'm finding, a lot of men have sleep apnea, and they don't know it. It causes extreme fatigue. You may not even realize how many times you stop breathing when you sleep. So that's something you can have done now. And if you're snoring, if you even think you might have sleep apnea, I highly recommend you get tested.
Yeah. And so that's a good point. Thank you, Dr.
Yeah.
Stone, because that's exactly where I was going. Um, I don't know why, but well, I do know why. Say that. But sleep apnea is very prevalent now, but I think it is still very underdiagnosed. There's more people who walk around with sleep apnea than they realize. And I was gonna lie and say I don't know why, but I know why. Because we're getting bigger. Uh, but sleep apnea can cause your blood pressure to be very difficult to control. So if I have someone, they come see me and they're on multiple blood pressure medications, and the blood pressure is still not well controlled, I start looking for what they call secondary causes. Um, Dr. Lee talked about some of those conditions in African Americans that make us hold on to sodium more. It's called hyperaldosteronism. There's labs that we can do to test for that, and that helps us know what's the best blood pressure medication for you. I'm going to ultrasound your kidneys to make sure that you don't have any blockages going to the blockages in the arteries that are giving blood flow to your kidneys, because that can make blood pressure difficult to control. But I'm also going to ask you a series of questions. Do you snore? And when you tell me no, I'm going to say, how you know you sleep? Do you sleep with someone and they tell you that you snore or you stop breathing? Are you, when you wake up in the morning, do you still feel like dog tired, or do you feel well rested? Do you have headaches when you wake up in the morning? Can you sit down and actually watch a movie on Netflix, or do you fall asleep? Do you have to take naps? Have you ever fallen asleep at a red light? Do you have to drink a lot of caffeine and Red Bulls to stay up? And I'm probably going to recommend that you go get a sleep study. Dr. Lee became my doctor here because I was waking up at night with my heart racing. I mean, racing, literally. Um, Very fatigued, heart racing during the day. And I said, I got to go see a cardiologist. So I went to see Doctors Lee and did a stress test and an echo, and the stress test was abnormal. And I said, oh my God, I'm going to have bypass surgery. And Dr. Lee came in that morning and he looked at me and he said, oh, this is going to be good. You're going to be fine. And I was. And then his wife sent me for a sleep study. And I had a severe sleep apnea. So I've been tired all this time. And I thought it's because I was, just a sleep deprived medical student, resident, and doctor. And I had undiagnosed, untreated severe sleep apnea, which just so happened to make my heart race at night, which just so happened to make my stress test abnormal. And now I sleep on a CPAP machine. And that thing got so good to me that I bought a little miniature travel one that the insurance don't even cover. So I don't have to lug the big one around. I just throw the little one in my bag and I'm good to go. So, but it is very underdiagnosed in our community. And so keep that in mind. Like you said, it ain't always your testosterone man. It could be sleep apnea. And did you know that untreated sleep apnea can contribute to erectile dysfunction? So a lot of times that'll get me to get my men to go get that sleep study. Yes, sir. Hmm. 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 Yeah. It's called excessive daytime sleepiness, which untreated sleep apnea can cause heart problems, can cause heart failure, can increase your risk of stroke and heart attack. So it's not just about getting a good night's sleep. It's the implications that it has on your overall health. Can contribute to, if you have chronic pain, if you have untreated sleep apnea, it makes your pain worse. It makes you depressed, more anxious, makes your blood sugar more difficult to control. Oh, it just does a whole lot of stuff. So get tested. Also, hypertension. At Archwell, if you come to us and you have hypertension, we are going to do a screening ultrasound of your heart. It's called an echocardiogram, because we want to detect any early changes that are happening in your heart from that blood pressure, so we can make sure we get you to a heart specialist to reduce your overall risk of cardiovascular mortality going down the road. calcium score. So I can tell you the primary care doctor's answer, and then I'll let Dr. Lee tell you the cardiologist's answer. So when we are trying to risk stratify people who have high cholesterol, and you're not high risk, but you're not low risk, you're kind of in the middle. A lot of times, what's called a calcium score, when you go get a CAT scan of the arteries, if your calcium score is not zero, then you're in that immediate risk or that intermediate risk. That can help me as the primary care doctor decide whether or not I want to put you on a statin cholesterol medicine. Because we don't just always willy-nilly put people on cholesterol medicine just because their cholesterol is high. We look at your overall risk factors. We look at things like your age, whether you smoke, if you're diabetic. Um, we look at what your family history is. We look at all these things and come up with a risk score, and we say, look, your risk of having a heart attack over the next 10 years is 8%, 9%, 10%. We need to put you on a statin, not because we're chasing numbers, but because those medications have been shown to reduce the risk of heart attack, stroke. If you have plaque in your heart or have plaque in your blood vessels, it makes it less likely that that plaque will break off and cause a heart attack or stroke. So that's what we are trying to do with those medications. But Dr. Lee, thank you. Thank you. So calcium score, yeah, yeah, yeah. Any other questions? Statins. Statins. Yeah.
Just to piggyback, uh, statins are the first line therapy for any kind of plaque. So if you're diabetic, we consider that to be a CAD equivalent. We don't even need to know about calcium. You're diabetic, you need to be on a statin. That's as a general rule, we do that. That's called a coronary artery disease equivalent. Diabetics are twice the risk of having a heart attack than non-diabetics. So we treat diabetes as a separate person, so a separate pool of people. So some of the stuff we're talking about now about calcium score and all this stuff, if you're diabetic, you're already kind of set apart. You're high risk. So if I have a diabetic who's never had a heart attack, and I have a non-diabetic, so we got two people. One's a diabetic, one's non-diabetic. My non-diabetic has a heart attack. The diabetic did not. But who's at risk for having a heart attack now? They're the same. The diabetic is still at higher risk because they're twice the risk. When you have a normal stress test, we do all these nuclear stress tests in the office. That doesn't mean you won't have a heart attack. It tells me that you're less than 1% chance of having a heart attack if it's normal. But a diabetic being twice the risk is less than 2% chance. So we don't even consider some of that screening for them. If you're diabetic, we just go ahead and you'll be on a statin. You have something called endothelial dysfunction. And really, I didn't want to go into the weeds with this, but that's really the root of all plaque buildup. All this hardening of the artery and calcification stuff, it all starts at the endothelium. The endothelium is that innermost lining of every blood vessel, every vessel in your body. It's thinner than saran wrap. If you were to dissect it out from every single vessel, some sources say it's bigger than a football field in terms of surface area. It's living. It has its own neurohormonal networks. There's certain hormonal things that can contract, it can expand. But if you injure it, the plaque pathology starts. And it doesn't, your heart doesn't, you have certain things like macrophages and certain signaling T cells and all these leukotrienes and MMPs and all this kind of, it's all of the molecular level activities going on where the statins turn that stuff off. It's more than just lowering your cholesterol. There's pleiotropic effect. We call this the pleiotropic effects of statins. So people can't take statins because their muscles get sore or they have all these other things. There's other medicines we can try. I went to the National Lipid Association conference in Miami 2 weeks ago. My family and I learned some new tricks down there. But by and large, they're getting some new technologies. They're going. My brother mentioned the coronary CTA and these calcium things. They're looking at lipid plasma volume to know just it's one thing to have plaque, but is that plaque stable or is it unstable? Unstable is worse than stable. So how do we start finding patients before they have those heart events? And that's where the technology is going to now. So I probably didn't answer your question. Calcium doesn't necessarily imply blockage. They do run together, but just because you have calcium, Sometimes, I mean, they do run together, but you can have just calcium with no critical stenosis. What we're looking for is plaque buildup in terms of intervening. I'm an interventional guy. In terms of putting a stent in someone or having to go to bypass surgery, plaque that's 70% stenosis is critical. If it's 50%, that's still bad, but it's not as critical to be intervened upon. And then we don't intervene upon every 70% blockage or more. Sometimes medicines work just as well as stenting. I love putting stents in people. I could pay for 2 weddings in college putting stent in everybody, but that's malpractice. And I'm way too handsome for prison. It's a joke, by the way. But anyway, but anyway, I'm just thinking, I wouldn't last a day. But anyway, but we're trying to prevent heart events. So all these things right now, that technology, looking for calcium scoring, we want to catch you with these kind of non-invasive ways to catch people before they have a heart attack. It's all about that kind of screening tool. That's a good screening tool. All right. Sorry to talk.
Yes, ma'am. Yeah, uh-huh. Yeah, yes, yes, ma'am. Um, so some of the weight loss medications, and like if you're talking about like the injections, particularly ones that they use for diabetes, like the Ozempics and all those, yeah, studies are showing that it does reduce risk, particularly in people who are diabetic. All right, they're still studying the in the cases where we use it for just weight loss and not diabetes. But I think that the same would apply and is going to bear out. There are a lot of medications now that we have multiple uses for. So it could be for diabetes, but it could also be good for your heart, could also be good for your kidney, can also be good to help reduce your sleep apnea risk and all of that. So I think that these weight loss medications, especially the injections, are going to be a game changer. And I just think right now, because they're so new and name brand, they're so expensive, we have a disparity. And the people who really need them can't afford them. And the people who can afford them, a lot of times, don't really need them, which is the problem with our healthcare system here now. If I answer your question, you can get me and Dr. Lee and Dr. Pauline in a room and we could just nerd out, have a good old time talking about statins and Ozempic and Wegovy and Repatha and that. Ooh, don't threaten me with a good time. Dr. Lee mentioned sodium. I'm sorry, before I went around, did my rounds at the nursing home yesterday, I stopped by Oh Yes Wings on 78. Had my favorite lemon pepper, all the way fried hard, all flats with ranch. I ain't checked my blood pressure, but I took my statin when I got home. No, I did not talk about clinical trials. Yeah, come on up here. I know, it's lunchtime, but we going
Y'all can't get rid of me. Um, I'm sure a lot of you have heard about clinical trials, correct? So clinical trials are extremely important because that's how we get our medications. But the problem is it's broken up into 4 phases. Phase one is when the dose is determined and the side effect profile is determined. That's all white people. So the majority of all the medications that we take have been designed based on one group. It's not a racial issue, it's a cultural issue. And the Human Genome Project has shown that the liver, a particular area in the liver, the cytochrome P450 pathway that metabolizes medications is different in people who are of African descent, Asian descent, Native Americans, and Caucasian. And it could mean that you can't have one dose that works for everybody. I got into this because if you look at mortality data in the US by race that's been collected since it began, the African Americans have the highest mortality from all causes and it has not changed. White people, as technology has evolved, as treatments have gotten better, they're living longer. So to me, it's not a genetic problem. I mean, that may contribute somewhat, but they are not doing the science in everybody in the country like they do on themselves. So it's important for you, if you have an opportunity to participate in a clinical trial, please do. I have a company called Clinical Diversity Solutions, and we're trying to press industry to deal with diversity in trials. Now, the government is moving in a different direction, which is going to put our lives at risk, but it's not anything new for us. So we're going to have to internally put forth the effort to participate, educate yourselves, or else we're going to continue to die at the same rate, and treatments aren't going to be as effective for us. So I'm on the Catalyst board. Catalyst is with Southern Research and UAB, and the goal was to bring genetic testing to every community in Alabama. That's that one that got cut for 44 million. So we're trying to regroup right now and find other ways to fund it. But it's important for us to participate in genetic testing because the next phase of medicine is precision medicine, where they're going to take your genetic information and tailor treatment for you. But if they don't have data on us, it's not going to be effective. So I'm on a national prostate cancer consortium, and we have a conference every November. We had the head of prostate cancer from the NCI give us a lecture, and they were talking about these new gene therapies that they've come up with for prostate cancer. And they were using them in white men, they got better, but they gave it to black patients and the cancer got worse. He pulled up the genetic map, you got all these blank spots. They call it junk DNA, but it's not junk DNA. They just don't have, they haven't done enough genetic testing on our men to fill in those gaps, which makes gene therapy potentially dangerous in people that you don't have the proper information on. So when you hear about it, don't be afraid, participate. We need all the information that we can get to be a part of the future of medicine, else we're going to get left out again. No, that's different. That's part of, that's won by the government. I'm kind of always suspicious of government things, but yeah, yeah. So I say still participate because we lack a lot of data. They got way less information on us than anybody. We have the most heterogeneous genetic code of anybody. We are mutts. We got, I don't know if you've ever done your 23andMe. I checked mine. I got like 15 different things, you know, from Eskimo to Native American to African, European. You'd be amazed what we're made up of. So participate. Don't be afraid. Yeah. So there's something called concordance. And over decades of looking at patients and outcomes and who has the best care, it turns out that when a Hispanic doc takes care of Hispanic patients, the patients do better. When a black physician takes care of a black patient, patients do better. Now, this isn't like all the time because there's some white docs and other docs that are very in tune, but having someone who has had the same cultural experience as you will improve your care. And I'm sure all of us have encountered those doctors and they don't hear you. They're not really communicating in a way that you understand. Um, I moved here from New York City. I was on faculty at Columbia University and I ran urology at Harlem Hospital. So my prostate cancer patients, I was referring the survivors to us too and some of these other survivors group. And then I had patients complaining to me. They're like, look, doc, when I get in the room with all these white guys with cancer, I can't relate. Hey, I mean, they don't, you know, my experience is totally different. So we started a group called Brothers Like Me, and it took off. So having people who had the same cultural experience as you has an impact on your care and your outcomes. Well, Well, the bad news is we have a physician shortage right now. We're retiring 71,000 per year, and we're only graduating 20,000. The numbers of black physicians have dropped significantly. All of our attempts to channel money toward our kids is being attacked. We have a scholarship at UAB that's under attack. We have a couple of friends that had scholarships. They've been returned because they violate the DEI law in Alabama. UAB is trying, but the far right has organized these lawyers. They are attacking every institution in the country that is doing anything that may suggest trying to help black or Hispanic kids. So it's going to come down to us looking out for us like we used to, you know. So we'll find another way to fund these kids. Can't give up hope. We were slaves before, so look at us now. And the other thing, don't be afraid to use a nurse practitioner. I have three in my practice. They're going to be the future. You know, they have to collaborate with a physician, but once we get them trained, they are as effective as we are. And in lieu of new doctors, which I don't see that being fixed in the next 50 years, uh, that's what we're going to have to do. You know, last thing I want is for us to end up like Canada and Europe with this socialized medicine. It may sound good, but it's not good when you live there. You know, it's not, you know, you have to get in line to get an MRI. You got to get in line to get a CT. You can't get access until you got to wait. And we're very used to having immediate access to care. And I think we want to keep it. Any other questions?
Thank you. No, that's good. That's good. Y'all give him a round of applause. Here comes Nia coming up here like the Sandman from the Apollo. But listen, y'all, representation matters. We do need people to participate in research. There's all kinds of research studies out there. And a point, especially for like cancers and everything, when you participate, people who participate in research trials for cancer, they actually do better because you're getting a lot of times newer therapies, you're getting more attention, more high quality care that you're not paying for. And so that's important. There's a lot of mistrust, medical mistrust, but there have been a lot of safeguards that have been put in place as relates to research now, like review boards and regulatory bodies. So Tuskegee and a lot of the other studies have taught us a lot about how to keep each other safe. And then finally, a shameless plug. We talked about a lot of stuff here. I have my own podcast. Don't have anything to do with Archwell, but it's on YouTube, Spotify, and Apple Podcasts called Prescription for Better Living Podcast. And I got about 47, 48 episodes. I'll talk about a whole host of all the kind of stuff that we talked about, including research and medical mistrust. So just check that out. It's time to eat lunch, and so I'm gonna call it Prescription for Better Living Podcast. Yeah. Or you can just visit drhernandocarter.com and get there. All right, here you go.
All right. Thank you so much, Dr. Carter. Thank you. Thank you. So, y'all, on that podcast, He be preaching sometimes, so just be on the lookout for that. But it's all great information. I am so appreciative to each of you that have come in today to lend your talent. We thank you so much for all that wonderful information. Because it is time to end the program, I need to know how many people in here have not won a raffle gift? Okay, we got 10 people and 9 gifts. So this is what we're going to do. You keep that. Okay. I'm just going to call the tickets until okay. It, it, uh, wait. Yeah, if you don't have a ticket, you can't win. You want to give her your ticket because you already run. Okay, I'm going to start calling. I'm going to call fast. Is everybody ready? Last 3 digits, 042. 042. 042. Going once, going twice, gone. 059. 059. 059. Once, twice, gone. 068. 068. Gone. 072. 072. 065. 065. Okay, I'll tell you what. This is getting boring. Okay, so the folks that oh, you won one. Did you win a prize? Did I call you? Oh, okay. Okay. All right, wonderful. After she picks. Okay, so the other people that have not won a gift today, make your way to the front. All right, how do you all feel about a pop quiz? Pop quiz. I hope all of you were here for. Okay, question. Who was one of our sponsors? Next question. Who is Archwell Health's community relations person? Me? Very good. Because you. All right. Next question. Who is, and please don't just blurt it out. I need you to, I'm measuring hand raises. Who is Archwell Health's medical director? Very good. All right, next question. What was the name of the mental health doctor that was up here? Last name. Mental health. Very good. Get your gift. Get your gift. Yes. Perfect. Next question. What was the name of the cardiologist? Dr. Lee, very good. Get your gift. Next question. What was the name of the urologist? Are you playing? Get to this. Urologist, Dr. Stone. Dr. Stone? Yes, urologist. Okay, we got two gifts left. They are umbrellas. Do any of you want an umbrella? It, all right. So, yes, Darlene, if you would like an umbrella, please grab. And Karen, if you want, oh, whoever, yes, there you go. All of them are gone. Thank you. Thanks for being good sports, everybody. Okay, so lunch. We do have lunch. It is out in the hallway leading up to the fellowship hall. The fellowship hall is closed, so this is a situation where you will grab and go with your lunch. If you feel like you want to eat it here at the church, you cannot eat it in this sanctuary. You can find a way found around the circle here, or you can go in the conference room if you want to eat the lunch here. When with that, we're going to go ahead and close out. Pastor?
Thank y'all.